Now, VIA, in addition to HPV DNA testing and Pap tests, those are the 3 recommended strategies. And you might ask, well, why not Pap tests? They've been working so effectively and have helped to decrease the incidence and mortality of cervical cancer in numerous countries. However, they require a lot of infrastructure, the availability of cytopathology, and the number of visits required to complete that process of screening. So if a woman comes for a Pap test and she has to return at a later date to learn of her abnormal result, and perhaps another visit, perhaps elsewhere, to have treatment, that has not proven effective in many, many settings, to the extent where we're really not recommending it if it doesn't already exist in a country. We prefer to say, start with VIA, get those skills up. It does take a lot of training up front, and maintenance of those qualifications are very important as you start to introduce HPV-based DNA testing. Now, the price of these is still too high. The point of care diagnostic capacity hasn't really been, let's say, it's in trials now to make sure that you could do that test and have a woman just wait a short period of time, maybe less than an hour or 2. She might have childcare issues, she might be coming from a rural area, to be able to tell her that day she can go home and she doesn't have to come back for perhaps 5 years. For those women who are HPV positive, there's still a role for VIA, perhaps, as a secondary screen. So the question now, and it's an important research question, is what is the best algorithm for managing those cases which are HPV positive? So there's still some areas of research, but by and large we have those strategies that we understand well enough to recommend the basics, depending on what environment you're in.